the typical presentation in CML, the median white count is around 100,000. Most often you see all forms of precursors for white blood cells in the peripheral blood. Symptoms of leukostasis, the clinical syndrome associated with a high white count, typically only occurs when you go into blast crisis in CML, and the blast counts are very elevated. Two main theories of leukostasis. One is that you got increased blood viscosity, which is a direct complication of the large population of leukemic blasts, which we talked about before, are less deformable, and this causes plugs in the microcirculation impeding blood flow. And this can be worsened, and you got to be very frugal about giving red cell transfusions in the setting of hyperleukocytosis, because red cell transfusions can increase the viscosity of the blood, and you can trigger somebody from an asymptomatic hyperleukocytosis into a symptomatic with red cell transfusions. Diuretics as well, you start losing the fluid part of blood and you're going to get sludgier, even sludgier. So you have to be careful using red cell transfusions and diuretics in the setting of hyperleukocytosis, especially in kids. Local hypoxemia from the sludging and the hyperviscosity can be exacerbated by the high metabolic activity of the dividing blast. We talked a little bit about this earlier, but especially the AML blast can produce cytokines which can directly damage the endothelium and cause hemorrhage, which can add to the hypoxic damage already present from the reduced blood flow. The blast can then migrate into the surrounding tissues and cause additional damage. There's a lower incidence of the symptoms of leukostasis, as I talked about in CLL and ALL, because those blasts tend not to be as active metabolically, so they don't tend to release as many damaging cytokines. They don't divide quite as quickly as well. And so AML tends to be the worst actor, which is why you can get leukostasis at lower levels than you see in the LLs. Now, if you just look at viscosity, it looks like there's a dramatic rise in viscosity in normal folks. If you get to a fractional volume of leukocytes, that's about 12 to 15 mLs per deciliter. That's quite a bit, which would be an association of typical AML blast count of about 300,000 or an ALL blast count of about 600,000. And so it's consistent with the fact that, just by leukocrit, AML would trigger leukostasis before ALL. But we know that leukostasis can occur not at 300,000 with AML, but around 100,000. And so there's other factors, such as the cytokines and other active biologic response modifiers, as well as other conditional cytoadhesion and things like that, which lead to leukostasis at counts lower than just the crit itself, the leukocrit itself causing it. So the main clinical symptoms of leukostasis, as we talked about: pulmonary, it's air hunger, that would be dyspnea; hypoxia, lack of oxygen, with or without diffuse interstitial or alveolar infiltrates, if you look on chest x-ray or other imaging studies. You have to remember that if you do blood gases, that the arterial PO2 in blood gases may be falsely decreased in leukocytosis, because when you collect the blood before you actually do the testing, so it's outside the body, but lots of white cells sitting in the blood, those white cells are going to consume oxygen while you're waiting to do the test, so you'll get an artificial lowering of the PO2 in blood gas tests. With hyperleukocytosis when you're evaluating patients with leukostasis. Pulse oximetry tends to be a more accurate assessment of O2 saturation in these patients. Neurological, visual changes: headache, dizziness, ringing of the ears, walking funny, confusion, lower level of consciousness, coma, intracranial hemorrhage, And sometimes the intracranial hemorrhage doesn't occur acutely, but it can occur after you treat the patient, lower the white count, regain blood flow into areas which have been damaged because of ischemia, and then you get what we call a reperfusion injury. And if the endothelial linings or integrity is broken in those areas, once the blood comes rushing back to these areas, then it flows out into the tissues, like the brain, for example. And so you can get intracranial hemorrhage after treatment in these patients at times, which is sometimes when you feel bad because you win the battle and you lose the war, you know, and you get the white count down, you get the treatment starting to show some effect, you keep tumor lysis syndrome under control, and then they bleed into their head, which is really sad, but it happens. Brain imaging and with non-contrast CT and MRI is indicated in these patients to evaluate for patients that have neurologic symptoms, because you don't want to miss something else. I mean, you assume that it's probably due to the symptoms of leukostasis and hyperleukocytosis, but it might not be. So you need to make sure that there's not anything else going on. You don't want to use contrast because you've already got a problem with poor perfusion, and that might make renal function worse. About 80% of patients with leukostasis are febrile, and that's due to the inflammation associated with leukostasis. There may be concurrent infection as well as inflammation, so they often treat. It's sort of like acute chest syndrome in sickle cell disease, where you think that the sickle cell disease is causing the respiratory compromise, but often they may have a pulmonary infection as well, so you sort of shotgun it. You treat presumed pneumonia at the same time that you treat acute chest syndrome. Less common signs and symptoms of leukostasis include evidence of myocardial ischemia, which you can see with electrocardiogram, renal insufficiency due to all the issues leading to microvascular sludging and poor flow, and kidneys are very sensitive to hypoxic injury. Priapism due to blood flow issues, acute limb ischemia. If you start cutting off the blood supply to a limb, eventually you're going to have problems. Bowel infarction, so you can also the blood supply to the intestines. If you cut off pieces of the blood supply to the intestines, they can die as well. There's an entity, I don't know that I've ever seen it, but it makes sense reading about it, is that after treatment with chemotherapy, if you have lots of leukemic cells trapped in the lungs, and those cells start to die, you can get a locally nasty reaction to that, which they call acute lysis pneumopathy. So you can get basically an acute lung injury situation because of the lysis of the white cells after treatment. Laboratory assays. There can be interference with some laboratory assays, and we talked about this previously, and it's a consequence of the high number of blasts and the arterial PO2s and blood gases can be falsely decreased because of the enhanced metabolic activity of the cells, using up oxygen in the collection container that you've got the blood in. Even when the specimen is placed on ice and transport, you do everything right, you can get a falsely elevated or falsely decreased arterial PO2. So pulse oximetry is the oxygenation assessor of choice in this setting. Platelet count can be overestimated on automatic cell counters because blast fragments can be counted by the cell counters. They look at size, so they may think that these blast fragments are platelets and overestimate the platelet count. So manual platelet count and careful review of the peripheral smear is appropriate if a patient is behaving like they have a low platelet count and yet the culture or whatever, Sysmex that you're using says the platelet count's fine. It's always good to look at a smear and go, well, there's a lot of fragments here and there's not very many platelets, so maybe that's why we're having a problem. Potassium can be elevated due to release from the leukemic blasts during in vitro clotting, so you can get a falsely elevated potassium You can also get a real elevated potassium, so that can be hard to sort through. So potassium levels using heparinized syringes helps you be able to tease out between falsely elevated and real elevated potassium levels. DIC can occur in about up to 40% of patients that present with hyperleukocytosis. It presents with various degrees of thrombin generation, which can then lead to hypofibrinogenemia, increased fibrinolysis, which can lead to elevated fibrin degradation products or D-dimer levels. And this may actually get worse with the therapy as you bust up more of the white cells. It actually can make the DIC worse. Spontaneous tumor lysis syndrome can occur in up to 10% of patients who present with leukostasis. And it is characterized by elevated uric acid levels, elevated potassium, elevated phosphate levels, low calcium, and it may worsen as you kill the cells with chemotherapy. So, if we got a person that presents with hyperleukocytosis and is showing evidence of leukostasis, so clinically evident